Good afternoon, and thank you for joining the RLS Foundation's webinar titled Older Adults and RLS, What's Different? My name is Carla Diezenkowski, and I'm the Executive Director at the RLS Foundation. Before we begin, please be aware that all attendees will remain on mute during this hour. We thank you for the questions submitted with your registration. Dr. Richards will answer as many questions as time allows at the conclusion of her presentation. The surge in the use of web-based programs during the COVID-19 pandemic has created a strain on the system. If you are experiencing technical difficulty, switch to the audio portion as it uses less bandwidth, and be sure that your webcam is turned off. We thank you for attending and appreciate your patience and understanding with any technical difficulties that may arise during today's webinar presentation. After the webinar, you will receive an email with a link to the webinar recording. The webinar recording will also be made available in the member portal of our website. If you are not a Foundation member and if you would like to view this and other recorded webinars, we invite you to become a member today by going to rls.org. As always, individuals suspecting that they may have RLS or are experiencing a change in their symptoms should always consult a qualified healthcare provider before making a change in their current treatment plan. Information offered in this webinar is for informational purposes and should not be considered as a substitute for the advice of a physician. Visit our website to find an RLS healthcare provider near you. Dr. Richards is a professor and senior scientist at the University of Texas at Austin School of Nursing. As a UT Austin PhD graduate, she has practiced and conducted research to help older adults with sleep problems for more than 35 years. One of her latest research projects, funded by the National Institute on Aging, focuses on restless leg syndrome in older adults with Alzheimer's disease-related dementia. This study marks the first time that a new RLS diagnostic tool that she developed will be used in research on nighttime agitation and sleep in patients with RLS and Alzheimer's disease-related dementia. Dr. Richards, we thank you for sharing your time and expertise with us, and I now invite you to begin your presentation.
Thank you so much, Carla. Can everyone hear me okay? Carla, can you hear me?
I can hear you just fine.
All right, well, great. Well, I want to welcome everyone, and I'm very excited to share some things about RLS and sleep in older adults, which is a subject that's very near and dear to my own heart and life. So let's get going. So conflicts, I have funding from the National Institute of Health, and I do some various consulting work, but nothing that really conflicts with what I'm going to tell you today. So I want to just tell you kind of an overview of what in the world I'm going to be talking about today, so that you can kind of get in mind and listen maybe a little bit more carefully, because you know what I'm going to say. So the first I want to talk about is just simply give you a quick overview of just sleep in adults and what kind of sleep you may have had, if you're still young, or you may still have it, or that you may have had when you were younger, and then talk about what's different in regard to your sleep in older adults. And then I'm going to kind of couch that in context of restless leg syndrome, because it's very important that we talk about sleep in general. I think that that's one of the key factors about what's different, is sleep is different in older adults in general, and that affects restless leg syndrome. So I'm going to spend quite a bit of time just talking about how those two interrelate. And then I want to talk about two special circumstances that occur in older adults: dementing illnesses, and there's the most common one is Alzheimer's disease and related dementia, also Parkinson's disease briefly. And then I want to talk about hospitalization, which is something that all of us, not all of us, but many of us experience a little bit more frequently as we get older, and how that might affect your RLS and your sleep, and why that's really important to pay attention to. And then I want to talk about clinical recommendations for treatment, non-pharmacological and pharmacological. And I will tell you that I really want to focus on the non-pharmacological treatments. I'm going to talk about pharmacology briefly, and that is not my area of expertise. I can share some things with you, but I'm not the strongest person about the pharmacology and all the intricacies of the pharmacology for RLS. But I am an expert on geriatrics and sleep. And so that's kind of where I'm going to more focus when we talk about pharmacology. And I really want to talk about the non-pharmacological interventions because those are super important in older adults. And then last, we're going to have some questions. So that's an overview of what we're going to talk about. So let's just start with, what is sleep like for adults? So there's been some cool research lately on sleep and cognitive impairment. So I want to tell you how much sleep you need. With the average sleep need for adults, and that doesn't change as you get older, actually. It's the average sleep need is about 7.5, maybe up to 8 hours. However, less than 7 hours and more than 8 hours of actual sleep, not time in bed, is associated with cognitive decline in older adults, with cognitive memory decline in older adults. So we don't really know why that is, but it's important to know that, for all of us to know that, and to try to get the right amount of sleep. That 7 hours seems to be kind of a perfect amount, looking at aging from what we know right now. Normal sleep latency in adults is 10 minutes, and then sleep efficiency is 95%. So I've heard many talks on sleep before I really understood what in the world is sleep efficiency. So what that means, 95% sleep efficiency, is that an adult, a normal sleeping adult, might spend 8 hours in bed, and then 95% of that is 456 minutes, or about 7.6 hours of sleep. So that's what sleep efficiency means, and this is what in a normal adult. Let's talk about older adults. What happens when you get a bit older? This is not necessarily for anyone with RLS. This is just for people in general. We don't really know enough about many things regarding RLS and aging. So I'm just now talking about just aging, normal people in general in the whole wide world who are getting older. So we know that sleep efficiency, which we just talked about, is reduced in older adults compared to when they were younger. I'll say us, a longer time to fall asleep, takes us a bit longer, more awakenings at night, and longer nighttime awakenings, such as the sleep efficiency goes down to 80 to 85%. That's kind of important to know because it takes a bit more time in bed for us to get our magic number, 7.5 hours of sleep. There's also another important change in older adults in their sleep, and that is that this slow wave sleep is decreased, and it's different in older adults. It gradually begins to change from adulthood to the oldest old, such that we get less of this slow wave sleep. Slow wave sleep is super important because it relates to memory consolidation and processing of memory. So there's a lot of studies going on right now. There's several that I know of where researchers are attempting to increase this N3 sleep in older adults, and measuring the outcomes on their memory, so that we want to know if we can increase this in various ways. They're trying different medicines, various ways to do that. Can we improve memory? So that's a really important study to keep your eyes on, as you could do a Google search and probably find out a little bit more about it. About them, there's several. And also in younger adults, the N3 sleep is about 20% of total sleep. So about 20% of your, say, 7.5 hours of sleep is this N3 slow wave sleep. In older adults, it drops to only about 5 to 10% of the total sleep. And another interesting thing happens that we don't quite understand is that the amplitude of the waves, the slow brain waves, get smaller, shorter, slow brain waves. And we don't really know why that happens, but that also happens. And then, so that those first two are the most important. The third, I'm going to call it early to bed, early to rise, and I think we all probably understand what that means. Older adults, some older adults tend to go to bed earlier and wake up earlier, but that's not a universal phenomenon in any way. And to my knowledge, I don't think that it's harmful in any way either. So what are some causes for sleep problems in older adults? So what is it? So one of the things that happens to us as we all get older is that all of us have some proteins deposited in our brain that are associated with memory, and they can also affect the sleep-wake centers of the brain. And that is to the best of our understanding in research in older adults, that is one of the reasons why our sleep starts to change. We have some of these protein deposits, amyloid deposits in the sleep-wake centers of the brain. One of them is the suprachiasmatic nucleus, and I don't expect to test you on that after this talk, but that happens, and that's one of the reasons, and that right now is normal. The cool thing about these protein deposits in the brain is that there is hope that we're going to be able to remove those, gradually remove those with some new medicines. And I don't want to get into the intricacies of that. And sometime if you wanted to hear more about it, we could do that. But that is a promising intervention for the future. And then, so those changes in the sleep-wake centers, they just don't work as well. The neurons don't conduct very well. And so our sleep-wake gets a bit off kilter. It just isn't as efficient. We have changes that I just mentioned in our sleep as we get older. So the other thing that happens, and I don't really, sometimes I catch myself worrying. I think I worry more, and I'm a little more stressed and anxious than I used to be. I don't know if the rest of you feel that way, but from what I read, talking to friends, talking to patients, it does seem like that's the case with a lot of us that are older. And why do we worry more? Why are we stressed more? Well, we have families, we have children, we have grandchildren. Life is complex. They all have problems. We're concerned about that. We might be concerned about our health. It's not as good as it used to be. We might be concerned about politics. There's this joke about old men talking about politics, and I think we all kind of can get into worrying about politics as we get older. Maybe you didn't have time when we were younger, I don't know. The other thing that we experience more as we get older is grief and loss. We lose so many people through a lifetime, and that can certainly make you sad and interfere with your sleep. What I hear a lot in older adults is my mind just won't shut down at night. And so we're, just constantly going over all these things, these stresses, these worries, these anxieties, these children, these grandchildren, on and on, and we just can't shut it down. So we're going to talk about that a bit more. And then we have chronic health conditions as we get older. Well, I wish we didn't, but unfortunately, most of us develop a few along the way. And the ones that interfere often are those that cause pain and discomfort. It's very difficult to sleep when your arthritis is bothering you, of course, your RLS, I'm really not talking about that yet, but certainly that is a big one. But any chronic health conditions that cause pain and discomfort, and there's a lot more of them as we get older, even those that cause breathing problems, for example, laying down and you can't breathe as well, not from sleep apnea, which I'll mention in a minute, but just from like your heart doesn't maybe work as well as it used to, so it's harder to lay down and flat and sleep. So chronic health conditions. And then, of course, what do? We give lots of medicines in health care. We providers give lots of medicines for these chronic health conditions. A lot of those interfere with your sleep, unfortunately. We are learning that less is more in older adults for medicines. So that's kind of new, and we're learning a lot about that um, in research right now. So some common culprits, and I'm not going to get into every one. I would encourage you to look up your medicines you're on. If you're having trouble sleeping, you should be the expert on your medicines, because I would not encourage you to depend on your physician to be the expert on all your medicines. I would encourage you to be in charge of to know what are the side effects. I wish that I had done a little better job at that in my younger life, actually, myself. But here's some common ones: steroids, antidepressants. You guys, I'm sure, are well aware that antidepressants, the only one that really doesn't affect RLS is bupropion. A lot of antidepressants are contraindicated. They worsen RLS. So I'm sure all of you know that, but they also interfere with sleep in general, not just RLS. A lot of them do. A lot of cold medicines have Benadryl in it, very bad for RLS, and worsens your symptoms. The medicines for Parkinson's disease can cause daytime sleepiness and may disrupt nighttime sleep. And I'm not going to get into Parkinson's disease. You probably would want to have a whole talk on that and aging. I think that would be an excellent one to have as a future webinar. And then breathing medications like theophylline interferes with sleep. So many of the medicines that are used to treat these chronic health conditions worsen your sleep and maybe worsen your health because you're not sleeping well. And then, of course, there's underlying sleep disorders. And insomnia, chronic insomnia is much more prevalent in older adults. And I've mentioned why: all the stress, the worry, the anxiety, many things can get you into a cycle of chronic insomnia that could be separate from your restless leg syndrome. And then obstructive sleep apnea. I know you have whole talks on that. I would hope so, because that's something that the guidelines are that you need to be assessed for that. They can occur together. Obstructive sleep apnea and restless leg syndrome can occur together. So those are just a few of, I think, some of the more common sleep disorders in older adults that can be causes for sleep problems. So I want to talk now about some special circumstances that we have to realize as older adults may or may not happen to us, might happen to others, and we all are most likely praying that it doesn't happen to us. But dementing illnesses are more occur in older age. And then the most common is Alzheimer's disease, related dementia, and probably the next most common is Parkinson's disease. So the prevalence and the incidence. Prevalence is just how many various older adults have whatever it is. In this case, I'm talking about dementia, but in incidence is new cases like every year. But in general, as we age, the prevalence and the incidence of dementia increases. There's lots of data on that. And in the 90 plus age group, I just looked that up last night, 45% of women, almost half of us women, but only 28% of men have dementia if you're able to reach that 90 plus age group. And then over the kind of striking thing about dementing illness, and why I want to talk about it, is over half of older adults with dementing illnesses have moderate to severe sleep disturbances, not just a little, but moderate to severe. Some of the characteristics of their sleep are just worsened, I guess, as compared to just the older adult sleep. They have more difficulty falling asleep, increased nighttime awakenings, even more. They have decreased slow wave sleep and rapid eye movement sleep. There's a lot more napping in people with dementia, such that sometimes day and night just gets mixed up, so that sleep and wake that occurs throughout the 24-hour cycle. And there's there can be a lot of activity during the night in persons with dementia. So that one is something that we can talk more. I'm going to talk more about treatment in a second. And then just the health consequences. Why is this so important? These sleep disturbances in adults with dementing illness. It's the number one reason that older adults are placed in long-term care. And not many of us have it on our bucket list that we want to go to long-term care. Not many of us do. So we want to, try to preserve sleep and wake in ourselves and our loved ones. And then impaired physical function, including altered gait. Sleep disturbances are associated with that. Increased risk for falls because people are up and about. They're not sleeping at night. It's dark. They trip. They fall. Increased risk for frailty. Increased risk for further cognitive decline, as I've mentioned. Impaired functional and cognitive recovery after acute illness. Depression, social disengagement, and behavioral disturbances and agitation. So considerable risk from sleep disturbances in this population. So one of the challenges is I know all of you know probably more about RLS than I do because I can tell you about aging better than I can tell you about RLS, but RLS is diagnosed as you know from a clinical interview. Your physician interviews you, asks you about your leg discomfort, when it's worse, when it's better, a complicated clinical interview. Well, people with dementing illness can't answer questions. They can't remember that. So it's very we can't tell if they have it. So we about 10 years ago, the NIH gave me quite a lot of funding to develop a diagnostic tool that can be used in people with dementia so that we can know if they have restless leg syndrome and we can treat it. And that's what this is. This slide shows. It's called the Behavioral Indicators Test Restless Legs. It's very simple. And it still is, even though it's 10 years old, it's still not used as much as I would like to see in clinical practice. It is important to know if some of the sleep problems caused in people with Alzheimer's disease is caused by restless leg syndrome. And we need to pay attention to that. As you know, it's very debilitating and too little attention is being paid at this point by providers. And then one other thing I want to talk about as we get older, and one of you had a question about it, well, gee, what if I'm in bed, I can't get up, and I have RLS. So I just wanted to kind of talk generally about hospitalization, and we'll touch more on it related to RLS in a bit. But in general, hospitals are not conducive to sleep. And older adults, we're already having trouble sleeping, and then we're the ones most likely to be in the hospital beds, right? The problem is not this like short-term sleep loss from being in the hospital. The problem is development of this delirium is a very serious consequence of sleep disturbance in hospitalized patients in older adults. It's the sudden confusion and agitation associated with hospitalization and acute illness. And the cause, one of the major causes that has been identified in many studies over time is sleep disturbance during hospitalization. And so we still are struggling, I think, as providers in hospitals, nurses and doctors to assure that people have a good night's sleep, older adults in particular, while they're in the hospital. Some of the long-term consequences for older adults are psychiatric disturbances, and not just in the short term, in the long term. Immediate and long-term memory changes. We've done studies of people who had delirium and got out of the hospital, and their memory is still impaired several years later. And then also we know that delirium delays recovery from illness. So you should be asking for a good night's sleep when you're in the hospital. I'll tell you more about what you should do about that. So you should remind the doctors and the nurses that you require uninterrupted time for sleep. You're an older adult. You know what happens, that you can get delirium from this, and you need some time to sleep. It's amazing how they keep you so busy in the hospital when you're sick, taking care of you, so busy that you can't sleep. So what they do, and what I counsel, and I've counseled providers around the world on this, is that you should the providers, the nurses, the doctors, they need to plan that you would have uninterrupted time for sleep at night. A couple hours, a couple times, a few times at night. You won't be able to have the whole night, but if you can just have a few hours so you can sleep and get through a whole sleep cycle. So they can plan that so that that can happen. And then plan uninterrupted time for napping in the day, because you're in the hospitalization period, you're not going to be able to sleep a whole night because they're going to need to do various care activities. So you need some uninterrupted nap times, and they can do that. They can put a sign on the door, and let that happen. They draw blood at 4 o'clock in the morning, and that's for the convenience of many people, but not yours. So I would don't allow, when my husband just had surgery right before the pandemic, and I wouldn't allow them to come in and draw blood before 6 o'clock in the morning. They like to come in at 4 a.m. and that's terrible. That shouldn't be happening nowadays based on what we know about delirium. And then if you have so many visitors that you can't take a nap in the daytime, you have control over that, you and your family. And it needs to be quiet. I've spent a lot of nights in hospitals. Sometimes they clean the floors, they vacuum the carpet, they empty the trash cans in your room. It can be really noisy. So you have a right as a patient to demand a quiet environment. At night, you can ask for earplugs. They should have those for you at night, and an eye mask if light's bothering you. The light should be dimmed at night so that you can sleep, and the bed and the pillow should be comfortable. Ask for a different pillow if it's not comfortable, not what you like. For example, my husband has CPAP, and he cannot sleep with a big fluffy pillow. It doesn't work well with his CPAP. And so we always get those. We go to the hospital and we ask for one he wants, and they send us some. So remember that hospitalization and sleep sleep is just as important in the hospital as it is at home. And it's even more important because none of us want to develop delirium, because it has serious long-term consequences. So now let's get to the main topic, and that's restless leg syndrome. So I think you all know what it is. I learned from Carla that most of you are long-term members of the RLS Foundation. But just in case, it's restless leg syndrome. It's uncomfortable leg sensations, sometimes described as painful. It's associated with the urge to move to relieve the leg discomfort. That's why your newsletter is called The Night Walkers. And the discomfort is worsened in situations where you can't get up and move. You're on enforced bed rest in the hospital, for example, on an airplane. It just gets worse and worse. It usually disturbs sleep in the first part of the night, and in the latter part of the night, the symptoms in general let up and are much better. And folks who have RLS can sleep better. In general, most data, and this is general, again, the data is not as good as I'd like to see, but most data indicate that RLS is more prevalent and more severe in older adults. But it may not always be, so it's not something you necessarily expect. You may not always have this happen to you. And again, the data is not that good, but in general, that's what it does support, that more prevalent, more people have it, and it can increase in severity. And so why? Well, why is it more prevalent? Why is it more severe? Well, it's unclear from a biological perspective why this occurs. I have looked for this and tried to understand it. There's some hypotheses, and maybe someone else could explain that better. But from the data that I have examined, it does not appear that there's a clear biological reason why it occurs in older adults, why it might be worse. So, however, I can explain at least part of it from a behavioral perspective. So, age-related sleep changes that I've spent quite a lot of time talking about it, and coexisting sleep disorders exacerbate RLS. We know that it worsens sleep and exacerbates RLS. And then having RLS further exacerbates sleep changes and coexisting sleep disorders that may occur with aging. So I think it's maybe more of what we call epigenetics, in the aging process, if you will, interacting with whatever we know about what's causing RLS in people and is making it worse in older adults. So your aging related sleep changes, your RLS, changes in the sleep promoting centers in the brain, all of this are interacting, and sleep is worse and RLS is worse, and they're kind of perpetuating one another, if you will. That's from the best I can tell, I believe that at this point, the best explanation, because we really don't have a better one. So to try to give you something that you might be able to use to help you, I'm going to start with these. And I think that in geriatrics, we talk all the time about how we want to use maybe a bit fewer. We need, medications are not so good in older adults sometimes. So we want to really focus on those things, the non-pharmacological things. And it does not mean that, I'm not saying that you don't get any medicines to treat your RLS. I'm saying that we really want to emphasize, probably more than ever before in your life, trying to find some things that can help your RLS, can maybe help you to use less medicine, or that will help you, that are not that aren't medicine. So, again, we don't. One of the biggest needs right now in RLS research that you can advocate for is that we find things that work that aren't medicines, because the older adults are the people that kind of can suffer from that because of just some of the toxicities. I mean, the difficulties from drugs in older adults. We know that. We try really hard to give the lowest amount that we can to any older adult. It's not for RLS, just in general for medicines. So it's really important to identify what is it that we can do. And there has not been enough research in non-pharmacological interventions to treat RLS. There could be a lot more. So the RLS, we have some one of the new research priorities that we've just approved is focusing on non-pharmacological interventions, because we just don't have enough data to really know what works. I'll tell you what I think works and what I know will improve your sleep. And so maybe together they can help. So here's what we know just about improving sleep. So consistent sleep and wake schedules, even on weekends. That's super important, is to try to keep to that. Create a bedtime routine, relaxing as much as you can with your RLS symptoms, using things to kind of distract you from your RLS symptoms, like music or reading or baths or ice baths. I think it's whatever works for you, but a regular routine, this comforting routine, has been shown in many studies to be helpful for insomnia, and I'm not sure why it wouldn't help also at least some for RLS. And then a good sleep environment. It's amazing the people I know who don't have a good sleep environment and really haven't thought as much about that as they could. But a comfortable, inviting and cool, comfortable bed, comfortable pillows, and then finish eating at least 2 to 3 hours before your regular bedtime. Exercise, I think, is one of the things that has been shown to help both sleep in general and RLS. And I highly, highly recommend it. And I think that we don't really know what exercises are best. I had a wonderful question, and I think I'll answer it early, from someone who said they're 84 and they're tired of walking and they don't really know. They know they need to exercise, but the energy's low, and the exercise helps their RLS. And of course, it helps your sleep too. but what's the best? I guess walking. I mean, yoga there's several studies that show that yoga practice might be really helpful for RLS. Some studies, they're not as good as I would like to see. The quality of the work but there are several that show that yoga, especially as you get older, yoga is a really safe exercise, and so is walking. Um, but I guess I think that you would want to try different ones to find out what helps you, since we don't have the data to say this helps in everyone, at this point. So it would be more like, oh wow, this one seems to really help my RLS and help my sleep, this exercise. So exercise is really important. And then, of course, the general rule is don't exercise within 2 hours of bedtime, but gee whiz, that's different for people with RLS. And then caffeine and alcohol. In general, I think you guys know about both of those are exacerbate RLS, and they certainly just keep you awake. We say no caffeine after 2, and your physicians may have suggested that you eliminate caffeine and eliminate alcohol in general if you have severe RLS that is really hard to treat. And one of the things that I've noticed, and this is just personal observation that might be helpful, is that I enjoy wine. My husband and I do, and I have very mild RLS symptoms, but I do notice that certain wines that have high tannins seem to increase my RLS symptoms. I haven't read anything about that in any of the literature, but I do notice that. So that might be something to kind of just observe if you do drink alcohol, as to which ones might worsen your symptoms if you enjoy wines. And then I think it's really, really important to keep a good diary of your RLS symptoms and what you did, what you ate, what you drank. Because in general, we're all the ones, each of us is the ones responsible for our own health in a lot of ways. We have a provider, they tell us what to do, our healthcare provider, but we're the ones that are going to have that detailed information that we can share with our provider, or that can help cue us to what exercise is better, if we need to cut back on caffeine, or if we need to drink a different kind of alcohol, if we drink alcohol, or drink no alcohol. But keeping a really good diary can help give you cues and your provider. And then what we tell all people who have insomnia is, if you can't fall asleep or go back to sleep after you wake up, it's really no need to fret about it. I've given you statistics about, gee, you need 7.5 hours. It might influence your memory if you don't get it. But one night is not, 1 or 2 nights is not going to just really severely affect your memory. So what I would say is, you can get into the cycle of worry. So I have problems. I'm the sleep person, and I still have problems sometimes, and I don't sleep well, but I don't try not to fret about it. I do know that if I don't sleep well tonight, I'm likely to sleep well the next night. And I try to pay attention to, gee, what did I do this night? Or this day, what affected my sleep? Caffeine for me is really potent. I have a tendency to drink too much, so I know that that's part of it. And then I've identified lately that sometimes some of the wines I drink are causing me problems. So pay attention to your body. So again, some RLS general treatment guidelines. We think in sleep medicine and RLS that primary care physicians, it's important that primary care physicians become more and more familiar with RLS and take a leading role in its management. I think all of you know that iron is very important in RLS, and certainly iron replacement is incredibly important and one of our best treatments. In older adults, and I don't have many slides about this, in older adults have chronic inflammation, so just a ferritin level is not what I recommend, and no geriatrician would for older adults. You need to do an iron saturation panel, and that should be what you, if you're older, base your iron replacement on instead of your just the serum ferritin, if that's what you're used to getting when you're younger. It's really important to identify any other sleep disorders, because there is this perpetuating cycle. Sleep disorders worsen RLS, other sleep disorders, RLS worsens those, as I spoke of earlier. And then the role of medications should always be considered, that those things that you're taking might be causing or worsening your RLS. And that's particularly important for older adults. So here's one of the terms we use a lot in geriatric practice is deprescribing. That's kind of a trendy word right now. So we recommend that that each medicine be evaluated in older adults because of the many side effects. So antidepressants, neuroleptics, dopamine blocking, antiemetics, and sedating antihistamines, which I mentioned earlier, Benadryl-containing medicines may be contributing to RLS symptoms, and discontinuing them if possible is important. And then other sleep disorders, as I mentioned, might exacerbate RLS. Clinicians taking care of you should be asking you about your symptoms of obstructive sleep apnea, and because they can occur together. Older adults are more likely to get obstructive sleep apnea. Our muscle tones aren't usually quite as good as we get a little older, and so that also includes the airway muscles. So obstructive sleep apnea, having it can worsen your RLS symptoms. So if you have snoring, your observed stopping breathing, it's very, very important to get that treated and use your CPAP. And then patients with RLS can have lots of other causes of insomnia, and I mentioned some of those earlier, and those require also treatment. And I mentioned chronic health conditions. One of the first things always for sleep problems that we try to do is to optimize medical conditions with symptoms that negatively impair sleep, such as treating painful conditions, treating nocturia. As we get older, a lot of us have that interrupts sleep. And so we want to try to treat those medical conditions that can worsen sleep. And then pharmacotherapy for neurologic and psychiatric disorders that have sleep disturbances as a manifestation. But always, as providers, we have to consider the risk-benefit profile for any of these drugs any medicines that we give older adults. So in general, the guideline is that fewer medicines and lower doses are better in older adults because of the many interactions and side effects of them. That's a general rule. That doesn't, again, mean that I think, you need fewer or you need less, but in general, that's the rule that we follow for caring for older adults. So some RLS specific recommendations. So mental alerting activities such as video games, crossword puzzles can help reduce symptoms at times RLS is acting up. Again, I've mentioned quite a few times caffeine and alcohol. I've mentioned iron. And then this is for intermittent RLS. These the carbidopa, levodopa can be used for intermittent, very, very mild use, very, very mild RLS. And then in certain cases, low potency opioids can be prescribed. And then chronic persistent RLS, the treatment current medicine seems to be that's prescribed most often are alpha-2 delta ligands, gabapentin and acarbol, pregabalin, unless some patient factors suggest that a dopamine agonist might be better or safer. And some of the things that would favor a dopamine agonist would be people who are overweight, have obesity complications, depression, gait problems, because there is, for example, gabapentin and acarbol, there could be some instances with dizziness and gait instability, which could cause falls in older adults. You may not have those problems if you're on this medicine, but you should be aware of it and pay attention in case you are feeling your gait seems to be changed or you are dizzy if you're on gabapentin and acarbol or one of the two other alpha-2 delta ligands. And then the other thing, any disorder that if you have a chronic respiratory failure for any reason, any breathing issues, severe asthma, then alpha-2 delta ligands may not be for you. But again, you would work with your provider, as Carla mentioned when we spoke. And then any history of substance abuse, because the interaction of certain opioids and alpha-2 delta ligands can cause respiratory depression in high doses. Although we don't usually give enough of the alpha-2 delta ligands for RLS, that would be a problem, but it can happen. So in an drug abuse situation, it could. If RLS is present for much of the day or the night, you might the providers might consider the use of slow release preparations, gabapentin and acarbol, or one of the patches. So those are some of the recommendations from the most recent updated. This was just published a few weeks ago. The management of restless leg syndrome. And then what about specific recommendations for alpha-2 delta ligands in older adults? This new guideline recommends less, 300 milligrams, as opposed to the 600 milligram dose that we would normally prescribe in younger adults for those persons that are 65 years or older. So that would be something to discuss with your provider. And then adverse effects should be carefully monitored. I've listed them here: drowsiness, dizziness, and steadiness. I mentioned steadiness with your gait, some potential for cognitive disturbances, although I've given a lot of it and I haven't seen that. But some edema, weight gain also could occur. A big side effect is if you have any history of suicide, being on alpha-2 delta ligands, particularly gabapentin and acarbol, it can increase the risk for suicidal thoughts. And then I mentioned also respiratory depression, those who have underlying breathing disease or in combination with opioids. And then I've already talked about substance abuse. And then, however, the alpha-2 delta ligands can be really good for older RLS patients because often, as I mentioned, we have chronic pain and insomnia, but perhaps best at the lower dose. So I want to talk about non-pharmacological interventions, and then I think I'm about to wrap up here so we can have questions. So cognitive behavioral therapy for insomnia is the standard for those able to engage in it, and particularly important for older adults. As if you're having trouble sleeping, get outside, go outside, get some bright light, take a long walk in the sunlight. Even these light boxes that are available, I think you can get them on Amazon, at least an hour a day of bright sunlight. In Texas right now, it's really hard to get that because it's cloudy every day and rains almost every day. But maybe a light box if it's really sunny or you're in Washington State. So social activities, keeping busy, being busy and active really helps sleep in older adults. I've done many studies, so have others. So we recommend that staying active and busy, that will help your sleep as an older adult. So getting out, being active, with your friends, your family, playing card games, whatever you enjoy. And then I mentioned exercise. I talked a lot about it earlier, but please remember that to help you with your sleep and your RLS. And then I mentioned yoga. There's lots of kinds of yoga. There's meditative yoga, which can be really helpful. There's progressive muscle relaxation, which is an excellent technique. And then melatonin for chronic insomnia might be helpful. So again, medicines that are FDA approved for treatment of insomnia are used off-label or on this list of the Beers list. And that means they can be potentially inappropriate for older adults due to the side effects outweighing the benefits. So there's a lot of them. So here's a list of them. Benzodiazepines, this is separate from RLS. This is just aging. Benzodiazepines, the GABA drugs, the Z drugs, including zolpidem, antihistamines. I've mentioned some of them before. Those are contraindicated for RLS. It means they're potentially inappropriate for older adults, not anything to do with RLS. And so we try not to prescribe them. Hypnotic agents that are not on the Beers list include melatonin agonists and low-dose doxepin. And then off-label use of antidepressants, anticholinergic antidepressants are on the Beers list, while low-dose trazodone is not on the Beers list as particularly potentially inappropriate for older adults. And then some other drugs, we don't have enough information, the orexin receptor antagonist. And then we do not recommend any antipsychotics for improving your sleep. There's very serious side effects in older adults, including strokes and death. In the hospital, I talked about what you should do. You should ask these questions. You should be an advocate for yourself for sleep in the hospital. And I think I mentioned most of these already. And then I think I mentioned all of these. Avoid Benadryl, whatever you do. And lastly, I'm going to try to answer this question, and then we'll have questions. How do I know I'm getting enough sleep? You're rested, you're alert in the daytime. You don't need caffeine to stay awake. You're not eating a lot of carbohydrates to stay awake, and you're not just napping all the time when you don't want to. I think we're entitled to nap some as older adults, but we don't want to be constantly engaging in unplanned napping and inappropriate situations. And then we want to fall asleep within about 15 minutes of when we go to bed. And as in RLS patients, you wouldn't really be going to bed until your symptoms kind of start to abate a bit. Fewer and no awakenings, and then you fall back asleep if you wake up. And you shouldn't be having loud snoring or breathing pauses, because that's a sign of apnea. And then I'm done now, and I've talked fast. I'm ready to hear your questions. Thanks for your patience and being here today. So questions, Carla?
All right, let's go ahead. Are there any exercises that help a senior citizen with RLS?
Yeah, well, I mentioned, talked quite a lot about exercise. I think the yoga is actually it's a kind of low impact, and walking might be two of the very best. But again, I think experimenting to find out what helps your RLS and what helps your sleep. And that's very, it's very individualized. And also what you can do physically. How your bones and joints are as we get older, those aren't the best anymore sometimes. So it's very individualized. So I think experimenting, finding that group of exercises that helps you, and then doing them. Finding a study, like a partner to exercise with. Like myself, I have my wonderful partner Linda and I do yoga together. We did it during the pandemic because we were both pretty safe. We wear a mask. Sometimes being in classes helps a lot for you to continue to do exercise. That's the problem with exercise is, to be honest, is that it's hard to keep it up sometimes.
Okay, our next question is, as one ages, how can one tell the difference between memory recall problems caused by Lyrica and the onset of dementia?
So I don't think you can. So I think that's a question that you really want to talk to your provider about. you can't tell. And so I think anytime that you're having as older adults, you're worried about your memory. I think that you really should go to your doctor and a good memory clinic, a neurologist that specializes in memory, because there are some things that can be done. We can't cure Alzheimer's disease yet, but we do have some things that we might be able to help you with. So I think you shouldn't assume that it's a medicine or that it's just normal aging memory. Get some help.
Okay. Is worsening of symptoms inevitable as we age? And is there a strategy or research to address this problem?
Worsening, I'm sorry, of RLS as we age,
I
is
think
that?
that's what, yeah, I think that it wasn't
Yeah.
there, but I think that's what's intended.
Yeah, I spent a lot of time talking about that, and I wish that there was a magic pill or a magic bullet or something that I could tell you. I think treating the sleep problems so that there's that perpetuating of RLS with insomnia, chronic insomnia, with apnea, with just the sleep and aging and sleep problems that we get, regardless of whether we have RLS or not, that perpetuates those. So following some of these recommendations that I mentioned, and for treating the insomnia, using as many non-pharmacological interventions as you can find. There's all kinds of things in the literature, but I've mentioned the things that I think are the best. So I would try them, and then get any other sleep disorders treated. The cognitive behavioral therapy for insomnia is wonderful. There's been so much research on it, and it's really effective. So I would highly encourage that if you just have chronic, insomnia that can coexist with your RLS.
Okay. Our next question is, it's difficult to get medical professionals to take RLS seriously when we are young. How are we supposed to convince them as elders?
Well, how do you do it? Well, I think that they have, 10, 15 minutes to spend with you, and it can be really hard. So I think, providing some literature, taking an article with you, is one way. I think finding that provider, they'll pay attention. Sometimes you have to shop
Mm-hmm.
for them. You're not married to them. You can easily divorce them if they're not taking care of your problems. So find one that pays attention to you, and attention to you holistically, and also know something about older adults. I think that's so important because we're not the same as younger people. We have very specific needs. So someone that understands RLS but also understands older adults is
Okay.
what I would suggest.
Okay. And our last question is, I'd like to hear about the RLS research that you're currently working on.
Yeah, so we have hypothesized that RLS may be one of the causes for the sundowning that occurs in people with Alzheimer's disease. RLS symptoms begin about the same time that sundowning does. Sundowning is this increase in agitation and worsening sleep that occurs in people with Alzheimer's disease. So we think that it's not being recognized and diagnosed and treated in older adults. And so that's what we're doing. We're identifying it in older adults who have this sundowning phenomena and attempting to treat the RLS. And then we'll see if we can also help them with their sleep and their sundowning behavior. As you know, the sleep and the sundowning behaviors, the number one reason why people have to go to the nursing home. So the idea being that we can
Mm-hmm.
improve that, we can improve their quality of life, it can improve their caregivers' quality of life, um, and help them to sleep better, and perhaps delay even their worsening decline if we can improve their sleep and their RLS symptoms. So that's what we're hoping to do. We would be finished with the project now if it hadn't, if we haven't had the pandemic, because we have had to halt like all research has. We're getting going again on that,
Mhm.
and very excited about finishing the project. We hope to finish in about the next 8 months.
All right, well, keep us up to date on that project. And then I'd like to thank everyone for joining us this afternoon, and thank you, Dr. Richards, for presenting. This was really, really helpful and informative. And I'd also like to invite everyone to join us next month for our webinar. Go to our website and you can register there. And we also have monthly virtual support group offerings. There are 4 of those a month that the foundation has, and you can hop on and meet other fellow RLSers and learn some tips and tricks to help you manage your RLS. So we look forward to seeing you, and everyone have a great afternoon.
Thanks, everybody. Bye-bye.
Bye-bye.